Good afternoon. My name is Kirk, and I will be your conference operator today. At this time, I would like to welcome everyone to the Methods for Increasing Medication Adherence with HIV-Positive Parents conference call. All lines have been placed on mute to prevent any background noise. After the speaker's remarks, there will be a question-and-answer session. During the question-and-answer session, all lines will remain open. If you'd like to mute your line, you may press *6 on your telephone keypad. If you wish to speak again, please press *6 to unmute your line. If you wish to submit a question at any time throughout the conference, you may do so with the WebEx chat function located at the bottom right corner of your screen. Thank you. Ms. Amanda Hopping-Wynn, you may begin your conference.
Thank you. Hello, everyone. I'm Amanda Hopping-Wynn, Project Analyst here at the National Abandoned Infants Assistance Resource Center located at the University of California at Berkeley. Funded by Health and Human Services Children's Bureau, our mission here at AIA is to enhance the quality of social and health services delivered to children and families affected by substance abuse and/or HIV by providing quality training, information, and resources to the professionals who work directly with these families. On behalf of the Resource Center, I'd like to welcome all of you to today's teleconference training with Dr. Jane Simoni and Karen Ingersoll, entitled Methods for Increasing Medication Adherence with HIV-Positive Parents. Dr. Ingersoll's research focuses on behavioral treatment development for addictive behaviors and problematic health behaviors. Specific interests include studies of motivational interviewing and empirically supported therapies to enhance clinical outcomes for substance users with HIV/AIDS, enhance medication adherence, prevent fetal alcohol spectrum disorders, prevent STDs and unwanted pregnancy, and treat addictive disorders in medical patients, including pregnant women and those with pancreatitis, liver disorders, and pain. Dr. Simoni's research interests lie primarily in clinical health psychology. She studies coping with trauma, chronic illness, and other stressful life events, and is particularly interested in whether individuals from historically oppressed or stigmatized groups experience unique stressors or exhibit culturally specific coping processes. Dr. Simoni's current research includes a large project to evaluate the effectiveness of peer support and two-way pager messaging to enhance antiretroviral medication adherence among a population of HIV-positive clinic patients in Seattle. I'd like to welcome all of you and Drs. Simoni and Ingersoll, and at this time I'd like to turn the call over to Dr. Ingersoll.
Hi, everybody. Good morning or good afternoon, depending on where you are. Welcome to the call. We met, Jane and I and Amanda and Ellen, last week to talk about how to proceed with this training, and what we decided was that we really wanted to hear from you about what you would like to get out of this call. We have a number of slides and things that we could talk about, including things like an overview of adherence, specific adherence studies, specific techniques to improve adherence, including some technology-based techniques. But we're really interested in hearing what you would like to learn today or talk about today, and we'll develop an agenda based on your input. So I guess I'd like to have the line open so that everyone can chime in. From my screen, I see that we have Jackie, Linda, Maria, Rayanne, Susan, and Mary Beth on the line. Would it be okay, Jackie, if we start with you? What would you like to get out of the call today?
All lines are now open.
Hello?
Okay. Let me repeat that question. I was turning to Jackie Ward for some input. What would you like to get out of the call today?
Just to get more information in reference of how HIV parents are being treated medically and also psychologically as well.
And Jackie, what kind of work do you do with these patients or parents?
Well, I work with single parents that currently are suffering from a substance dependency disorder, but I have not had a parent that has been HIV positive, but I want to know what are the interventions if indeed I get a parent that has HIV.
Okay, so some general information on the medical treatment of HIV positive adults. And you're specifically working with single parents, especially those with substance abuse issues. Great, thank you.
Yes, thank you.
And can I turn next to Linda?
Yes, and I guess what I'm looking for today are just maybe looking at different strategies that might assist me in helping some parents be better about taking their medicines and really looking at it from a client-centered approach that's really more strengths-based rather than judgmental. Because I think they tend to hear a lot of, when they go into the clinics, it's kind of more finger-waving and this is what you need to do, and so I'd like, from a social work perspective, to be a little more client-centered and supportive.
Okay, excellent. So, Linda, are you a social worker working with patients?
Yes, I work with patients from a variety of different clinics and do a lot of work with women that are pregnant and also adolescents that are positive and their parents.
Okay.
And medication adherence is usually a very high priority for us, but often, you know, families are faced with so many different issues that it's hard to kind of help them prioritize.
Okay, great. All right, Maria, can we turn to you next? Do we have Maria on the line?
Yes.
So, Maria, tell us a little bit about the work you do and what you'd like to get out of the seminar today.
We're in Philadelphia, and we have a home-based program working with HIV-positive caregivers, majority mothers, and their infants and toddlers. And we provide services in the home, a team of mental health specialists and parent-child specialists. We have a very high-risk population. We have seen in the last 2 years drastic changes in the health of participants in the program. We have had, I think it's 4 deaths in the last year and a half. And one of the most challenging issues in terms of engaging caregivers and retaining caregivers is adherence to medical care. We collaborate with hospitals. That's where we get our referrals from. But it seems to be that adherence rate, is decreasing as number of HIV-positive women is increasing. So I would like to hear what you have to say in terms of engagement and retention, and what strategies you will recommend.
Okay, great, Maria. So, wow, you work with the population, and you've experienced more deaths than anybody would like to see in the past 18 months. And so it's mostly HIV-positive women with poor adherence that you're concerned about.
Definitely. Definitely.
Great, great. Let me turn next to Rayanne. Can you tell us a little bit about what you do and what you'd like to get out of today?
Hi. I work with primarily women who are often involved in family services, not always, but often, and who are parenting often alone and are chemically dependent. And
hold on. Go ahead, Rayanne. And just as a reminder, if you need to mute your line, I believe it's *6.
Okay. Is that what I should be doing, is muting my line?
Just the background noise, just for the background noise. You should continue talking.
Yeah, go ahead, Rayanne. So you were saying they're mostly women in family services who are single parents. Are they HIV-positive women? I'm not sure if maybe Rayanne accidentally muted herself.
It appears as though she has muted herself. One moment.
Okay.
Rayanne, your line is open.
So, Rayanne, I was saying it's women in family services who are single parents. Are they HIV-positive women?
Not often. That's not something I deal with often.
Okay.
But on occasion.
But I'm guessing they have multiple life stressors.
Yes, and chemically dependent. And
okay.
And so just hear more about this information for as we come across women who are HIV positive, HIV affected, and so more information about serving them and assisting them, and also with clients that might have both HIV and Hep C, because we have a high incidence of hepatitis C, and I know that there's often people with Hep C are often more susceptible to being infected with HIV.
Sure. Okay. Excellent point. All right. Let's turn to Susan.
Good afternoon. Good morning. I've been listening to everyone's feedback, which has helped me sort of synthesize what I would like to get out of today's webinar. My role is in maternal pediatric HIV/AIDS in a medical center, and I realize that Linda, hello Linda.
Hi Susan.
I am Janine Jason Gay's successor, and we've spoken by conference call through the North Carolina Children and AIDS Network, NCCAN. My location, Brody School of Medicine at East Carolina University, is one of about half a dozen or more pediatric AIDS networks throughout North Carolina, and my title is essentially case manager, and it's a new role for me. I've been here a little over a month and a half, so I've been a social worker for a while and even worked in pediatric AIDS a long time ago, in the dark ages, about 20 years ago in Philadelphia, but not in direct service. And so I'm really keen on learning all I can about all of the above, but certainly engagement, retention, strategies for those things. And I'm particularly interested in motivational interviewing in the context of the psychosocial piece, the counseling with some others. So I meet with the moms in clinic, with the PEDS ID, pediatric infectious disease physician, and we sort of tag team. And so I'm assessing and also providing counseling. And so I would like to know how to not finger wag and be a supportive, proactive force, arming myself with, anything that's out there in terms of what works. So I guess those are my my objectives in a nutshell. Thank you.
So you've also got high-risk populations, and you want to know a lot more about engagement, retention, adherence, and what works in counseling. And you're on to something when you're talking about MI or client-centered as opposed to finger-wagging. So I'm sure we'll get to that in a minute.
Yes, and definitely medication adherence goes without saying. Thank you.
Okay. I see a couple of other people on the line that we haven't queried yet. The next one on my list is Mary Beth. Mary Beth, are you on the line? Well, let me turn to Michael.
Yes, I'm here.
Michael, tell us a little bit about the work you do and what you'd like to get out of today.
I am an HIV nurse working for the health department, and my job basically is to triage the patients that come in to our providers, and if they're there for an appointment, find out if there's any new issues regarding their HIV care or even other health issues. That we also take care of their primary care, which could be managing their diabetes, cardiovascular issues, etc. And I'm also a patient educator, so I'm always looking for information on how to keep HIV-positive people in their care, and medication adherence is a big part of that.
Okay. Excellent. Thank you, Michael. And looks like we have another participant, Omira.
Hi. Good afternoon. Go ahead. Oh, I was just going to say, I work primarily with within the Child Welfare Agency in Broward County, Florida. So my unique population is substance abusing children substance abusing parents of children 0 to 3, also if they've been affected by HIV or AIDS. So we're really working on the reunification side, trying to help them make sure that they not only take care of themselves, but also learn the parenting skills that they need to be reunified with their children.
All right. And what would you like to get out of today?
Just ways to learn to just kind of help the parents along without having to be like their mom. Or, I mean, they get something like that from the doctors anyway, so it kind of like trying to be alongside, using a solution-focused approach and being positive, but at the same time saying you really do need to stick to your schedule.
Okay, okay. Looks like we've gotten feedback from everybody except Mary Beth. I don't know if Mary Beth is back on yet. Okay, well, not hearing her, I'll just summarize a little bit about what I've heard from all the participants on the line today. So I've got to say, in summary, I'd say you're working with tough populations. You've got women, single parents, people in charge of infant and toddler care while having substance abuse problems. You've got really high-risk populations, and you're concerned about things like Hep C, co-infection, and HIV. And the content that you've asked for sounds to me like it falls in a couple of areas. One is sort of HIV treatment in general, but more specifically, how do we really engage people so that they will be adherent, engage them and keep them in care, and how do we influence their adherence, but in a respectful and collaborative way that doesn't feel like we're becoming their parent or that we're just repeating maybe a negative communication that they've gotten that feels like people are telling them what to do. Does that sound about right to everybody?
Yes.
Yes.
Okay. Well, given that, here's what I would suggest for an agenda, and Jane, please chime in. You know, we could do just a couple of minutes to get a little overview of adherence, to define some terms and to get us all on the same page with that. And then perhaps open it for discussion between me and Jane and everybody on the call about some of the sort of newer techniques and what the evidence really is for things like motivational interviewing with adherence. How does that sound to everybody?
Sounds good.
Great.
Yeah, this is Jane, and hi, everyone.
Yes.
And Karen, that sounds great. And even a couple of the slides, we talked about general strategies. And it would be great, I think, as a group, if we could share what's been working.
That's right. That's right. Okay. Well, let me, let's see, Ellen or Amanda, it looks like I have the desktop control. Is that right?
That is correct.
Okay. I'm going to just go through a couple of slides of some general points about adherence. And we'll do this kind of quickly so we can get to our discussion. So there are different types of adherence, and several of you have mentioned, you know, there's a difference between engagement in care, which we typically think of as that initial phase of hooking someone into the idea that they need to get engaged in care and maintain a relationship with HIV care providers. And this is a big challenge, especially if somebody you know, is initially diagnosed with HIV. It's very common for folks not to engage in care for 1 to 4 years after initial diagnosis is sort of the median. Then there's the more typical definition of adherence. Medication taking is one we're all concerned about. And depending on the other illnesses that patients may have, and people living with HIV often have a number of other health conditions, they can have other kinds of adherence requirements. For example, somebody who has a kidney disease often has dietary or fluid restrictions. And if we think about adherence more broadly, it might also include behavior change adherence. So things that, especially if you're working in a case management role or a psychotherapy role with a patient, you might be trying to encourage them to take steps at home to actually improve their adherence or their engagement over time. And for my money, the most important element once these things are sort of rolling is that the patient actively participate in their own treatment, that over time they become able to advocate for themselves. So I've got just a couple of slides about, who's reaching this special bar for adherence, which in HIV really is 90 or 95% or more. We're asking patients to be extremely adherent to what can sometimes be a very complicated regimen. So a recent review found that there are higher rates of adherence.
Karen, sorry, this is Jane. Are you meaning to go through the slides? I'm sorry to interrupt you. I thought you had a couple slides for these, and we're still showing the title slide.
Oh, well, see, I'm seeing these slides. Is everybody else not seeing the slides?
I'm not. This is
we're seeing
Susan.
There it is.
Yeah. Yep. Thank you.
Now I'm seeing it.
Okay, thank you. Sorry about that, everybody. I thought I was showing those. But anyway, so you can see higher rates of adherent patients in studies that have more white patients as opposed to other racial groups, more injecting drug users. So among those substance abusers that you have, more IDUs tend to be adherent in these studies. Fewer men who have sex with men, fewer methadone maintained. The lower the development index of the country, so if we're thinking internationally beyond the U.S., those countries that actually are poorer tend to show better rates of adherence, and better rates in those with earlier infections and HIV rather than AIDS.
And Karen, Ellen actually took control over the slides, so if you can just say next, she will be advancing them for you because it didn't seem to be working the other way.
Okay, so go to the next one. Okay, now because most of you are working with drug users, I also wanted to highlight a couple things about the drug user population specifically in terms of HIV adherence. So there was a large study by Malta and colleagues in 2010 with almost 15,000 patients. And the bad news from this study and this meta-analysis is that the average adherence rate was far lower than what we want to see, only about 60%. What that means is that these patients are actually the ones who are at highest risk for treatment failure for their HIV. We know that if you are 90, 95% adherent, you're unlikely to develop resistance mutations, meaning that the virus can sort of take over and replicate faster. But it's the people right in the middle, 50 to 60 or so % adherence, that we're most concerned about because they're intermittently adherent. And that means that they have medications in their system, and yet without good adherence, the medications fall below what's called a trough level, where they're not really effective anymore, but the virus can mutate in the presence of the medication. And so this can lead to treatment failure, meaning that whole classes of medicines no longer work well for that patient. Now, among drug users, there are subsets who still do pretty well, and there are better outcomes for those who are in recovery, so former drug users as opposed to active drug users. Those with lower psychiatric severity, so a less complex picture than someone would say several psychiatric illnesses plus substance abuse. People in opioid substitution treatment, so that could include buprenorphine or methadone. Supportive drug treatment recipients, so those just getting counseling, can also do well. And people who started their treatment for HIV began their HAART regimen with a lower viral load and higher CD4. Usually this means that they have not had opportunistic infections, they have not had as much immune compromise, and so we're really working to preserve their good immune health. And pertinent to someone's comment, patients with HIV alone as opposed to HIV plus hepatitis. So the good news is that there are drug user subsets who in these large studies have been able to achieve better adherence. The not so good news is that the average adherence rate is far lower than we really want to see it. And it sounds like this is something you're observing in your populations. And if we look just at drinking,
Karen, can I add one thing to that?
Jump right in.
This is Jane. Yeah. So another positive thing, I know we're focused on, more empowering messages for our clients, is sometimes it's not just whether a particular individual is using drugs, but the fashion in which they're using them and how disruptive the habit is to their lifestyle. So many active substance users still can maintain pretty good adherence. It's not ideal. It's a lot harder to do when you're in the throes of an addiction. But even people who are active users can remain adherent if they're able somehow to work the regimen schedule into their daily lives. So I think that's a
really important point. Yeah, and in fact, I suspect that's part of what's behind some of the findings with opioid substitution therapy, because patients who are in that kind of treatment actually have a fairly regimented schedule, daily schedule, whereas I've worked a lot with crack cocaine users, and that particular pattern of drug use tends to be in a binge pattern, and, while they're using or looking for drugs during that period, they tend to not do any of the other good health behaviors we want them to do because it's a very disruptive experience. So excellent point, Jane. Can we go to the next slide? The one that says, how does drinking affect adherence? Does everybody see that? Okay. So drinking also can be quite disruptive, and problem drinkers are about half as likely as non-drinkers to be adherent. And in fact, even just problem drinkers and dependent drinkers were similar. So I think this goes back to the point we were making a minute ago that, the disruptiveness of competing behaviors like drug use or drinking is part of what gets in the way of people's adherence. Let's go to the next one. So there are a couple, so far we've been talking about patient factors, but I want us to remember that provider factors are also related to adherence. And despite this, we have a small evidence base. We tend to do a lot of research on patients and patient factors and a lot less on providers. But since we're all clinicians working with patients, I wanted to add this slide. There is a little bit of evidence that adherence is better when you do a couple of things. First one is you develop trust with your patient. So, whatever counseling techniques you're using or rapport building techniques you're using, you're developing a sense of trust. That you actually take time in your conversation to tailor plans to their real situation. And that, of course, builds a good treatment alliance. When they feel understood and like you are on their side despite whatever their status is, whether they've had their kid taken away or whether they're a drug user, they'll usually feel a better rapport with you. Another surprising thing to me was that providers who telephoned patients at critical times to check in had better rates of adherence. And critical times in HIV care are things like whenever the regimen is changed, or if the person is going through a personal crisis, or if their schedule is changing in some major way, such as a vacation or some other shift, maybe a new job that has a different schedule. So providers can telephone patients to check in, hey, how's it going? How are you fitting your medication in, given these changes? And that tends to be a successful strategy. And, of course, a patient has to believe that the regimen of medicine is going to help them to be invested in taking it. And so providers who are more successful at developing a larger pool of adherent patients tend to give hope and strengthen their belief in the regimen. Just one or two more, and then we'll open this for discussion. Next slide. Adherence is a skill. Adherence is often paired with things that are challenging, substance abuse, psychopathology, depression, stressful life experiences. We're asking people in the context of that real life to develop this skill. But the good news is that skills can be learned and taught. They do need to be practiced and to be reinforced until they become a part of someone's routine. And given that for HIV adherence, patients will need to be treated over the course of a lifetime, these skills probably need periodic refresher courses. They can be improved. We've seen a number of HIV adherence interventions that are successful, at least in the short time. But pertinent to what several of you said, they require motivation. So even if a person fully understands what to do to take their medicine and to stay on top of their schedule for that, they have to remain motivated to get it going. And that's where all of you come in, the people who are working directly with patients. So here's the last slide I want to talk about before we open it up. This is key intervention targets. There are a couple things that we know that influence adherence negatively, and one is simple forgetfulness. It's difficult sometimes for people to prioritize medication taking in a chaotic life or even just a very busy life. So there have been a couple studies that showed that folks with sort of high-powered jobs and a lot going on in their lives who were considered socially functional could be just as likely to forget medications as those who are homeless. So reducing the impact of forgetfulness is part of what we want to talk about is how can we as clinicians help patients. And of course, attending to our own relationship with the patient. Do we have a good relationship, a good working relationship? And if we don't, or we don't feel a connection, what can we do to build that connection and make it stronger? And as I said earlier, my real bias is I want to see patients develop an ability to advocate for themselves, and that means I want to help patients become more involved in their own treatment planning because that builds their investment. So let's stop with those slides for now, and let's open it up for a little discussion before we go on.
Can we make sure all the lines are unmuted at this point? And if you do have your phone on mute, if you could push *6, that will unmute you so you can join the conversation.
All lines are unmuted again.
Okay. So based on what I've talked about so far, what's hitting home for you, or what areas do you want to talk about some more?
Mike, can I just speak?
Yes, go right ahead. Anybody chime in, feel free.
Thank you. I'm very new to this. I've been in HIV care for only about 5 months now. So I'm looking for any ideas that will help motivate people to be in charge of their own care. And I guess that's what I'm expecting from this whole conversation today, too, is just a few points that you know work or most people will find it works. So I'm going to kind of sit back and kind of listen to most of what I hear today.
Okay, so you're really interested in focusing on how do we help people get motivated for adherence.
That's right. If I could just give them that pill every day, I feel like that would be a huge breakthrough.
Okay, excellent. How about from others?
This is Susan. I have been made aware by a colleague who's been in the field for many years that especially with teens who comprise a large proportion of clients of ours, in addition to the younger children, but with the older children / young adults, we see people up until the age of 23 in our clinic, at which point they're obliged to go to adult ID. But embracing technology such as something like myMedSchedule.com, which is a really neat thing. It's free. It's a reminder for people as to when they need to take their medications, and they can receive the reminder through their cell phone, for example, or by email, or all of the above. It's also in Spanish. Of course, that requires that someone have those technologies at their disposal. Also, a hard copy of a graph, a printout of one's medication adherence, or, well, let me back up, their lab results, which may or may not be linked to their medication adherence. There could, of course, be other things going on. But this, I've been told, is also, or can be, a point of curiosity for our young people in our clinic. Many of them ask for this, and it seems to spark their investment in their care. So I just wanted to mention those two things, tools, if you will, that I've become aware of in my brief time in this field as well.
That's great. And actually, Jane has for many years worked on the technology side. I've now got a text messaging project that I'm working on. Maybe we could spend a few minutes talking about those studies and sort of what we know so far about how technology can help to motivate and engage people with adherence. Jane, do you want to jump in?
Sure. I didn't know, did you have some slides on your research you wanted to show?
We might get to that. I can also summarize it just verbally, but I know that, you know, you've done the pager studies that might be really interesting to people, because that is something that overcomes forgetfulness and provides a reminder and might be similar to the technology that we're hearing about now.
Yeah, sure. There's been a lot of optimism and high expectations about how the role of technology might be able to help with health behaviors like adherence. A recent review of the literature showed that, however, there's no magic bullet in adherence, and some of the most basic techniques, although they're helpful, they're often not enough. So things like a pill box alone or a simple reminder. Sometimes people set their cell phones, or sometimes you can get little technology, the ALR, remember, a little reminder. Looks like a little something you could add to your keychain. It's just an alarm device that you could set to beep at certain times.
I'm going to interrupt you just for a moment. I just want to let you know that you do have control. So if you want to switch to your slides, that's an option for you.
Okay, maybe we'll just finish the conversation, and then when Karen's done, maybe I'll go on. Okay. But one of the main things I found about technology, and this is particularly important for the populations you all seem to be working with, is that you really have to treat the patient in context, and in the context of their own lives, in the context of the other sometimes overwhelming problems that they're also having. So giving someone a pillbox reminder or even a chart, which could be helpful to someone who's able to manage that when they're actively using substances, they're in a domestically violent relationship, they have other, they're in unstable housing. Those are not going to be enough, obviously, to be able to deal with adherence. We have to deal with the larger picture, the bigger context first. But I like to think of the technology as yet another tool in the toolbox that you have for adherence strategies that can be helpful, can be effective in some populations, but not to over-invest in them or think that it can do more than it really is capable of doing. I don't know if you wanted to add anything to that, Karen.
I think that's a really excellent point. For my money, the most important factor in fostering engagement and adherence is your relationship with the patient and your efforts to really understand their perspective, which might include their other life problems. So, a mistake would be to approach somebody for HIV care as if HIV is their number one priority. Oftentimes it's not. Oftentimes it's number 4 or 5, and realistically that's appropriate. And so despite that, we're really wanting to make a relationship with someone that is focused on their perspectives and their needs so that they feel understood and they have something to gain. They can see that they have something to gain from remaining in a relationship with you. At that point, you might offer a number of strategies, such as technology aids or memory aids and pillboxes, things like that. But Jane is totally right that it's up to you to form a relationship first and really engage the person at the level of what they're perceiving their priority is.
Yeah, and I think I can add to that. There was called the Wealth Health Study in Kenya that got some decent results in terms of using a simple text message sent once a month in a local dialect, just what's up, how you doing, how are things, and if people wrote back, doing fine, good to hear from you, there was no more intervention. If they didn't respond or they wrote back, I have some questions or concerns, there was a follow-up. So in this intervention, it's often touted as an efficacious intervention for text messaging, but I see it really as the power of the relationship that the participants and the patients have with the provider. that they were staying in touch with someone cared about them, someone was checking in with them, and if they had a question, there was an individual that they could get back to. So I think that shows that underlying it, what Karen was saying first, develop that relationship first, and then you can use the technology as a way to enhance that, but not to substitute for what's not there yet.
Yeah, I couldn't agree more. This is Susan again, and thank you for highlighting that point. You know, relationship.
Yeah.
Yeah. Mm-hmm.
Yeah. And I think that gets to the motivation aspect of it, too. Someone asked earlier, you know, I think it was Michael who said, how can we encourage people and motivate them to want to adhere? I mean, that's the hardest thing. It's hard to help people when they want to adhere, but if they don't and they aren't motivated, it's even harder. And part of that is building the relationship, getting to know the person, and getting to understand what would motivate them to be able to adhere.
This is Mike again. I just want to thank you for bringing up the point that we need to find out where is HIV in their priority list. Because I have been assuming that this is big to them in their lives, but obviously it's not.
Sometimes it isn't.
And I haven't found out what is priority number one, so I can work with them going down their priority list instead of working against them, which I feel like I've been doing.
Yeah.
Well, and that's often seen also with substance abuse. So, you know, I've worked for years with substance users, and oftentimes, you know, various doctors or treatment providers believe that substance abuse should be the number one thing that they need to work on and essentially eliminate, and only after that should they work on their other health conditions. But in fact, substance use is another sort of life choice and health condition that is going along with the other challenges the patients face. So, you know, going along with the challenges of parenting very young children, of, you know, being HIV or Hep C positive, all of those things. So you know, my preference when I'm working with a new patient who's usually referred to me either for fix their substance abuse or fix their adherence is I want to really understand their perspective, you know, almost like get them to paint a picture for me of the different life challenges that they're facing. And then I'll ask an open question like, you know, which one is most pressing on you now? Or which one are you most ready to talk about now? That's a motivational interviewing technique to elicit and evoke from the patient their own perspective and priorities. Because, in fact, I might be able to help them with that thing that they're seeing as their top priority. And if I do that, they're going to be more willing to talk with me about other things that I also think are priorities, but maybe are, you know, way down on their list.
So can I ask this, and this might be an obvious answer to this question. I know sometimes I feel like they're telling me what I want to hear, and I know that, and I'll even say, don't try to appease me. Just, you know, let's just have a conversation about what's going on in your life, because, you know, they'll even come in thinking that I don't know that they are crack users every day. You know, and I'll have to just kind of say, you know, I kind of know your history. I know you're doing this every day. So if that's getting in the way of your HIV, then let's talk about that. Would that be a good way to approach, you know, their priority list?
Well, I think you're onto something with trying to figure out what their priorities are. But even the way you just phrased that, is that getting in the way of your HIV care? They may not be seeing it that way at all. They may be saying, you know, to themselves, well, gee, I've got to continue to use and deal drugs to be able to, you know, afford a place to stay and, you know, put food in my baby's mouth. And what are you talking about HIV? That has nothing to do with this, you know. So my preference is actually to step back and take a bird's eye view first of, you know, what are the issues going on in their life now? What are their concerns? What would they like to be different? These are the kinds of open questions I might ask them to start to build a relationship. And I'll sort of start from scratch and say, you know, I'm here to work with you, but, you know, you're really the one to decide whether and what you want to change. And I'll be here to help you, but I'm not going to be here to tell you what to do. And that often relieves some of their defensiveness or their feeling like they need to please me.
Good point.
And if it does get around to adherence, you do get to that point. I like what people have already brought up, the solution focused, a strengths-based, more social work approach to say, instead of starting with what's getting in the way, tell me about a time you were able to take your meds this week. And I know when Doc used to say, gosh, if I were on these meds, I can't imagine taking care of the 2 kids you have. I don't know how you take them at all. But it sounds like you did sometime this week. You were able to take your meds. How did you do that? How were you able to do that? Let's talk about that. And then from that, get a sense of where their strengths do lie and help to reinforce those.
So I'm wondering what other comments and questions or concerns folks have. So we've talked about motivating people using some sort of basic counseling techniques, the use of technology sort of as an adjunct to the relationship, and helping patients to get to the point where HIV can be a priority for them to address. What else do we want to talk about?
Do you want to go back to some slides, Karen, unless there are more questions?
Sure. Are you thinking there's some on your set that you want to show?
Yeah, or did you? I don't have control yet. Did you want to finish? You want to tell about the research projects that involved MI?
Well, let's see. So do I have control, or Jane, you have control?
I have it right now.
Okay. Well, I actually, because of time, I'll just give you the bottom line. So we did a study with patients who were crack cocaine users. And, I see.
Is that helpful?
Sure, sure. You can move forward.
Okay.
So what we were interested in doing was testing a motivational interviewing approach that involved personalized feedback of risk, so essentially helping them understand why they were considered non-adherent, and also, what could be done to improve their adherence, and the role of cocaine with HIV progression. And we compared that to a video information condition that also involved some debriefing of what patients understood. We were hypothesizing that the MI condition would actually be better than the video condition, and we were looking at 2 things: medication adherence and drug use severity for their substance abuse on the Addiction Severity Index. Can you go forward, Jane? Or Ellen?
Ellen, do you have it now?
Yeah, these are some of the session activities that we had in our MI session, and in brief, we spent a lot of time on rapport building and making a relationship with patients, and we explored ambivalence with them, thoughts that they had mixed feelings about taking medicines. We heard things like, we had patients in our study who revealed that they felt that they couldn't disclose their HIV status to anyone. They might go to substance abuse treatment groups and not tell anyone there they were HIV positive. They might go to HIV support groups and not tell anyone there that they were a substance user. They felt like they didn't really fit anywhere and they couldn't be honest. And they were often ambivalent about taking medicines because many of our patients hid their medicines, put them in different bottles. We had one patient who hid them under the couch cushions because she was convinced that anyone would poke through her medicine cabinet and find out her secret. So these kinds of strategies, working on social support, exploring ambivalence, really building relationships, we felt like were very important. Can you go on to the next one? And so in subsequent sessions, we focused more on building their ability to make some changes, self-efficacy. And so we built their motivation and interest in taking their medicines perfectly, as well as reducing their substance use. Most patients entering this study came in explicitly saying, cocaine is ruining my life, and that's what I want help with, and adherence was a far lower priority in their mind. So we addressed both behaviors throughout the intervention. Can you go to the next one? So in the video comparison condition, we showed 6 videos that we thought were well tailored to the patient's needs. So we made sure we picked things that had good role models, accurate information, and most of these videos also had vignettes where they'd show a patient living with HIV talking about their experience so that we felt like the videos would be very relatable for the patients. But our intention really was for this to be an informational control condition. Let's go to the next one. I actually want to skip ahead a couple. Go to the next one. Okay, here's where I'd like to focus. What you'll see, these two lines, our intervention with the motivational interviewing was called HAART, and the other one was called video. The yellow line is the adherence rate among the HAART, or the motivational interviewing participants. You can see that we improved their adherence from about 63% up to about 94% at the first follow-up, which was 3 months later, and about 92% 6 months after baseline. So the intervention definitely had an effect, but what you'll notice is that the video intervention also had an effect. These lines are essentially parallel, and when we did our data analysis, we found that they really didn't differ. Now, this is a small preliminary study, but it really made us think what was going on in the video condition that might have explained why it worked so well. So our bottom line was we actually have identified two useful interventions. It's useful to develop a strong interpersonal relationship using motivational interviewing kind of counseling techniques, and that can help improve adherence. But even just giving information that the patients themselves tended to personalize seem to have a similar effect, slightly less strong in raw numbers, but really similar in terms of the data analysis. And the next slide. Let's go to the next one. So there were main effects, meaning that both interventions worked to also decrease the days of cocaine use. So we had both improved medication adherence and fewer days of cocaine use, but because both conditions looked pretty equal, I can't really say that motivational interviewing was superior to the video intervention. What we do think as a team, those of us who were involved in this study, is that the patients, when we did the debriefing with them after the video, we intended the debriefing to be just, did you watch the video or did you fall asleep? But the patients actually ended up personalizing it and started talking about themselves and how they related to the people in the video. So we felt like actually there were sort of unintended motivational elements built into the video as well. I think I'll stop there because of time.
That's amazing, Karen. Great effects for a population that would be typically pretty difficult to work with on that issue. I think, go ahead.
We had some people who actually stopped using cocaine entirely, but more frequently people were continuing to use. But what we saw was really, where previously they'd been using every 3 or 4 days in a month, they went down to maybe once a week across the course of a month. So a big reduction, but they were able to achieve good adherence even in the context of continued drug use.
Yeah. And I think the idea that you got an effective result both in the intervention and what was thought to be just a control group, I think speaks again to this theme that it's the relationship with, the study personnel and coming in and having someone ask about your adherence. That's important, very important.
That's right. That's right. And the other big message from my perspective was that, patients, we did a qualitative interview after the study, and they all said, I liked coming here, no matter what condition they were in. I liked coming here because it's the one place I had that I knew I would be accepted, even if I talked about drug use, even if I talked about HIV, even if I talked about other problems I'm having. And that was a really important message for us.
Yeah. Yeah. Did you want, I guess I have the control now of the slide. Did you want to show any of the other slides about mHealth or?
I don't think so, not for now.
Okay, okay. Okay, maybe I'll switch over to some that I have. Some of the background information we've pretty much talked about before. Both I guess there's some folks that haven't worked too long in the field, and remind them that HAART was only formally introduced in 1996, and it still is associated with incredible virologic, immunologic, and clinical outcomes, but and it has been dropped, a precipitous drop in mortality and morbidity, but that adherence really is a Achilles heel still. In studies where they actually can go into a place and directly observe every dose, they have 100% response to therapy. So just about all of the outcomes are, the variance in the outcomes can really be attributed to adherence. If people can take the drugs, they really do work. What we talked about motivating patients, sometimes what is less motivating is some of them are starting so early now, they don't have very many distressing physical symptoms early on when they start, so they lack the motivation that comes with suddenly feeling better. In Africa, they talk about a Lazarus effect. People come in sometimes being rolled in on a wheelbarrow. They can't walk anymore. And they go out within a month or so. They're up and have gained 20 pounds and are doing better. We don't see that in the United States because fortunately we can start people a little bit earlier. But the downside of that is it's harder to motivate people. Not only are they not feeling better right away, but sometimes they're feeling worse given the side effects that they have. There are dietary restrictions. Fortunately, a lot of the side effects are not as pernicious as they used to be. The drugs are definitely more tolerable. But there's other issues that decrease motivation at the start, things like stigma. Once people start to take the drug, they open themselves up, the medications, they open themselves up to having other people know about their HIV infection. Many of them haven't told the partners that they're living with. So just being on the medications, and as Karen said, having to stuff them under the couch, pillows sometimes, is a deterrent to them even wanting to start. Let me talk about some of the correlates of non-adherence. So we have about 25 minutes left. Some of these we covered, and then I'll go into some more of the specific strategies. But to keep in mind, the sociodemographic differences in terms of age, income, education, they don't seem to be great predictors of adherence, which I take to mean basically everybody has a hard time with adherence. It's not that any one group is doing worse than others. We have found, though, that there is one demographic characteristic that is pretty consistently associated with poor adherence, and that's race. African Americans in a lot of our studies are having a harder time being adherent with their medications. And we're trying to find out what exactly the reason is for that. We had several ideas at first, but some of them haven't panned out. It hasn't been depression, hasn't been substance use as far as we can study it. It isn't lower income or education or access to other resources. And we're left thinking it has something to do with the general impact of racial discrimination and stress, minority stress in terms of these patients' lives, and in terms of the care somehow that they're getting at the clinic. So that's still a question that's open for research. We found that patients who lack social support tend to do worse in adherence. Those who can't tell other people about their HIV for obvious reasons, right? They're not able to take their medications openly. Some of them will skip doses because they can't tell people about their medication. If they have poor general health and definitely psychological issues, it makes it harder for them to take the meds. In one of the studies that we did, we decided to treat depression at the same time as we're looking at adherence, and we had a lot of success with that. And that gets back to this issue of what is the most important factor right now in the person's life. It might not be adherence if they're suicidal. So treating the underlying mental health issue, basically depression, is something that can be very helpful in terms of improving adherence. There's the aspect of patient-private relationship that Karen covered, the regimen or illness variables. Don't forget to have the patient talk to the provider and make sure they're on the best regimen for them. A lot of people still haven't been switched to a once daily regimen, and if that's appropriate for the patient, that's something they should be looking into. And then the contextual factors. We focus a lot of the time on what the patients can do, but there's often things that can be done in the clinic setting in terms of making it more accessible to patients, providing child care if possible. I want to talk about some of the strategies. Let's talk a little bit about the slide here, innovative strategies to consider. One, we talked about technology a bit. Let's talk about social support, adherence interventions, and trying to remember if we had a slide. Okay, let's talk about this one. So when I started doing research a few years ago, we found that two of the major factors associated with people having difficulty taking their meds was depression and lack of social support. So we thought about how to improve that, and we worked on a program using peers, so buddies or peers, we call them at the clinic, who also were on medications, also patients at the clinic, but seemed to be doing pretty well. on their medications. We train them in just a pretty brief two full day program, and paired them up in teams with other patients, had them talk over the telephone or face-to-face, and then they would come to group meetings every other week, just once every 2 weeks. We did this for 3 months and found that it was helpful, at least according to self-report and some MEMS data, that people were able to better take their medications. And this is a program, actually CDC is working on getting an online version of this in one of its DEBI interventions. So people will be able to go online and get the training materials for this, and I'm happy to share them with anybody if they're interested. But I actually might want to take a minute now to open this up and ask people if they're using peers, what ways they've found them to be helpful, and if there are any challenges to using peer support as a way to increase both social support and education about the medications. Did anyone want to comment on that?
This is Sue. I'm aware that our adult infectious disease clinic for our positive adults does have several peer support and social support groups. They call them support groups, and it's something that I would very much like to see offered for our young people, and I've been thinking about applying for some grant monies. Again, the relationship and feeling understood by peers is a very powerful effect.
I think another major strength of the peer approach is how it decreases stigma.
Yeah.
There's only so much we can say as providers, but having other people who've actually lived through it is just so much more powerful with patients. And I just pulled up a slide there that shows the 3-month buddy intervention, and we also did have a pager component to it as well.
Can I ask, how difficult is it to get folks to sign up for this peer or buddy, program? Are they, do they feel comfortable sharing that with somebody just because they're positive, or are they still closed because it's still kind of an outsider knowing their business?
Yeah, it's a good point. I mean, we have a range of reactions to it. There certainly were people who came into the clinic, wore a baseball cap, pulled it down, and didn't want to run into anybody they know ever. One of these guys, we eventually got to volunteer to be a buddy, though. So even some of those folks are reachable, but some never are. It's not their thing. They're not going to talk to someone else that they don't know yet. They don't want to share. They're not ready. Some of them, active substance users, just aren't at a point in their life where they can commit to that or they can benefit from it in that way. So it's not something that I would, that applies to every single person at the clinic. There are other people, though, that it's especially helpful for, and I think early on in the diagnosis, early on when they're starting meds, it's particularly helpful to talk to other people about the early side effects, how they deal with them, questions about what they've learned about adherence strategies, how to talk to the provider. They're trained very specifically not to give medical advice, but they can help the patients learn how to talk to their own providers better to get that information. And we do.
And another critical piece about that, about the idea of matching someone with a peer or a buddy, is that oftentimes patients are living in terror of, they're the only one they know who's HIV positive. And even just the social support they get from meeting someone else who's HIV positive and doing well with their treatment can have a very important optimism-inducing effect.
Yeah, we definitely saw that. I mean, one thing I want to emphasize about peers, though, is not to underestimate that they do take a lot of support and a lot of supervision. It's not that you can train a bunch of peers and throw them out to the clinic and say, do some good. You definitely need structure in the program. You need some support. You need a lot of supervision. There's burnout and turnover in the peers. Even the study that we did, we had to retrain several times to get a new group of buddies going to be able to do the intervention. So it's not an intervention that runs on its own necessarily. You still need the supervision, but for certain patients, I think it can be very helpful.
Is this supervision that you're talking about, is it more beneficial from maybe a person who has a better mental health background to be the facilitator than let's say, an HIV nurse?
It can be both. Both would be ideal, but ideally someone with some counseling background, some kind of human service perspective would be probably most helpful.
I wanted to make a comment about the peer model. We're here with Maria.
Sure.
And I agree with, I think we all agree here with this, the person who talked about the need for structure and supervision, and that it needs to be sort of a highly organized program for the peers, because the peers are also they have very similar backgrounds a lot of times to the families, so there is the potential to go beyond the so-called intervention and, get, without proper supervision and guidance, start giving sort of advice and giving guidance in ways that may not be necessarily helpful for the families. So I think the training and the supervision is so important.
Yeah, it's funny. That's one of the things we specifically train them in, how to provide advice that might be helpful. And it's finding out if the person wants it, if it's been helpful with them, if they've had some personal experience with it. But yeah, they're taught generally not to come in and just tell people what they should be doing.
Dr. Simoni, did you say that there was training available? That you had information on how to get that training?
I do, and you can, I don't know, Ellen, how you want to facilitate this, but people can email me after, and I can actually show them the book we use for training. But within the next year or so, it should be up on the CDC website. This is a good resource for people. If they look on the CDC website and just look up Adherence Interventions, Debbie program, they can find a list of, I think we now have 5 or 6 interventions that have shown to have some validity, some evidence, empirical evidence for their effectiveness. And they'll have all the materials up there online for a program that can actually be implemented online. But meanwhile, if you're really curious about it, I can send you whatever.
Well, Jane, if you want, if you send it to us here at AIA, we generally send out an email after the fact anyway to our participants, and we can include the attachment in that email so that everybody gets it.
Yep, that'd be great if they want to do that too.
Okay, wonderful.
Excuse me, I was wondering too, Sue here, if you recommended any particular motivational interviewing training, which is very popular right now with good reason. And as a social worker, I know, for example, I have a plethora of sources, CEUs, continuing educational credits. Mike, I just wanted to suggest that there's a lot of sources that can be found online, among other places, in terms of training. But certainly, if you all can recommend some in the context of adherence and what we're talking about today, that would be even better.
Well, I can actually speak to a resource. We have a group known as the Motivational Interviewing Network of Trainers, the MINT, there's a website for the MINT, and it lists trainers by state and also by area of expertise. And so if you're interested in getting motivational interviewing training from, say, someone who's close by, who's a more local resource for you, but who is a member of this international organization that's known for promulgating the best practice in training on motivational interviewing, you may also find people with specific expertise in adherence and in HIV care.
That's great. Thank you. Very helpful.
www.mint.org or what?
I'm looking that up for you now. I'll have it for you in a minute.
Okay, thanks.
Does anybody else have any experience with peers that they would like to share? I know it can be a mixed bag sometimes. We hear a lot from the AIA grantees that like Maria's group was saying, that peers can work really well, but they can also bring a whole host of challenges that the agency may not have the structure to cope with.
Do you want us to comment on that, or?
Yes, please.
Could you repeat what you were asking? We were sort of listening, but.
Sure. You know, a lot of times we hear from our grantees that they love the idea of using peers and that they may have tried it, but that there has to be an infrastructure in place in the agency to really make it work, and that can be overwhelming. And so I'm wondering if these resources address that issue as well as just training the peer, but kind of providing an infrastructure in the agency. Karen or Jane, are either of you on the phone?
Are we alone?
Oh, no. It appears that way.
Sure. Karen, did we lose you? I think we heard that Jane's phone died.
Oh, I've been talking. Have you not been able to hear me?
Okay, there you are. Gotcha.
I'm sorry. I think I had my phone on mute. I was having a hard time hearing the question. I was hearing like every other word. I had a bad connection suddenly. But I did want to mention I found the reference to the Motivational Interviewing Network. It's Ellen, I sent it to you in chat, but I can't figure out how to send it to everyone in the chat.
I'll go ahead and send it out.
So
Okay.
if you look at the bottom right-hand corner of your screen, there's a little chat box there that Ellen's been chatting in. So you'll see the resource listed there.
Thank you.
But yes, I'm a big fan of people getting training in motivational interviewing. It's a really good fundamental counseling skill, even if you're not trying to use MI only. You've got a whole set of tools, as Jane said, but motivational interviewing specifically is a really good way to initiate these good relationships and to try to maintain a good relationship with the person you're working with. And we also did a peer study in New York City I was a part of, and we actually recruited peers who are part of a large HIV clinic and trained the peers to use motivational interviewing skills. They would go into hospital rooms of patients who had been admitted due to HIV, but they were not yet engaged in care, and they would introduce themselves using MI skills and share a little of their own stories. They were all HIV positive, past substance users, and so we were trying to get somebody sort of as similar to the patient as possible to talk with them about their own experience and try to hook them into care. And once the person was physically well enough, our peer would actually escort the patient down to the HIV clinic and start introducing them around just to sort of demystify the whole experience. So this is a strategy sort of similar to a buddy intervention, but it was more of a peer support for engagement intervention. And it looks to be quite successful. We've got a paper coming out in a couple of months on that.
This is Jane. I was off for a little bit. I'm sorry. I got back on. You know, I wanted also to mention, too, as another resource that the IAPAC, the International Association for Physicians in AIDS Care, has just come out with guidelines for engagement and retention and adherence for HIV-positive patients. And an article has just come out, and that we should probably send a link to that to folks because it talks about some of these strategies and ones that have been found to be most effective. But I thought I might, in the last few minutes, maybe go over some of the specific strategies slide, if that's okay, Karen?
Yeah, definitely.
Let's see. In terms of AHAART initiation, some of these we covered, so it might be a little bit of a summary and review at this point. Does that sound okay? Way to go. So at AHAART initiation, to provide information and support for the management of side effects, actually not pretending that the patients might not experience any, but instead letting them know that they might, but they can be transient and they can be treated. adopting a neutral stance about inquiring about adherence, or better yet, as people brought up, a strengths-based perspective, expecting non-adherence, but expecting to hear about ways that the patients do have strengths and do have the potential to adhere, even when it's difficult. The third would be collecting regular data, basically monitoring adherence. The studies have shown that even when people keep track of something, they tend to do better at it. If you tell them to go home and write down all the junk food you eat this week, you'll see it will decrease over time. So having people look at their adherence, having them track it, and asking about it every time in positive ways, in ways that lead to focusing on specific behavioral strategies for improving it, not for just punishing people who don't. Asking questions and really listening to the answers. They did some studies with Ira Wilson's group up on the East Coast, and they actually listened to the conversations with the providers and the patients, and they found, not surprisingly, that the docs tend to talk a lot, and that isn't always as helpful to the patients. But asking questions and letting the patients talk, making sure, asking for clarification about what's said is really important. Again, offering strategies and tools, some of the ones we've talked about today, avoiding closed-end questions about adherence. So just ones that they answer yes, no, instead of questions about what were the strategies, what are the reasons, what are some of the things that might be helpful to you. Promoting social support, as we said, one of the ways to do that is through formal buddy programs or even informal ways of connecting patients to others that might be helpful with in terms of taking their medications. For the long term and at periodic interviews, really just exploring, again, potential facilitators and barriers of adherence, and remembering that this isn't something that's done just once, or isn't something that's done just at the start of the medications, but has to be thought about in terms of the long term, developing a toolbox of adherence strategies that can be used over time, inquiring about reinforcing continued adherence, incorporating success into clinic procedures. Was at one clinic once, and when anyone got a lab back that showed an undetectable viral load, the entire clinic staff stood up and gave the person a standing ovation. It's very powerful for patients to experience that, both the one who had the success and those who were witnessing. And then sharing among patients some of the more successful strategies. And I think, let's see if I have one more. No, that's it. This is just an example of an electronic box. I make a disclosure that I did consult with this company for a while, but it's one of many that are out there now that you can use that for patients. Open each of these bins whenever they need to take their medications, so they can have several scheduled throughout the day. It can vibrate, it beeps, the light goes off. There's even a note that tells you how many to take, what the special instructions are. There's a snooze button if you want to stop and take it 30 minutes later. It's fairly easy to operate. And these can be hooked up to a telephone so that the clinic gets all the data. And you can actually call patients and find out, gee, you haven't opened the bin in a couple of days, what's going on? So it's great to use these technologies as a way to predict problems with adherence instead of always looking retrospectively about what went wrong.
How does a clinic access this kind of device?
They can buy them. You can go online to, I think one of the websites is like automatic reminders or pill reminders. And there are oodles of these devices now, some more expensive than others. And I don't know that they're worth implementing across the entire spectrum of the patient population, but with some individual patients it might be very helpful to know and to be able to monitor. But they're not without some cost, right? If they're hooked up to the phone, there's a fee for the service to be able to do it. But if you're thinking about just for maybe particularly difficult patients for a limited period of time, it might be something worth considering. I'm going to stop there and let either Karen fill in or Amanda wrap up.
I did want to just mention one other thing that's a novel project for my team, which is sort of pertinent to what we were hearing earlier about teenagers and the use of technology for certain patient populations being sort of a popular thing. I live in Virginia, I work at the University of Virginia, and we have mostly a rural patient population, quite different than New York, San Francisco, or even Seattle, in that patients are often quite isolated geographically. And so we are testing a text messaging intervention that we not only send them reminders when they're supposed to be taking their medicines, but we're also testing the possibility of getting information back from patients on their mood and on their substance use on a daily basis. And what we're trying to find out with this study is, first of all, will patients text us back about things like their substance use behavior? And we actually have a code that we teach them to do this. And we've done a usability trial, and patients loved it. So, for example, we would say, how is the weather? And if they texted back clear, that would mean they hadn't used drugs in the last 24 hours. If they texted back cloudy, that meant they'd been smoking marijuana. Rainy was they'd been drinking, and so on. And at least in the initial usability trial, patients would text back answers about their mood, their medication taking, and their substance use. And our hope is that the text messaging happens about 4 to 6 times a day, and it will become like a doc in the pocket, that, you know, the patients will see their phone as their ally, their connection to the clinic. And our ultimate goal is to keep them engaged in treatment and care, as well as collect some information on how do these things relate on a daily basis. So I just wanted to mention that there are other groups as well testing different variations of a text messaging intervention. And I think for adolescents especially, or young adults who tend to walk around with their telephone all the time, you know, they're never far from their texting, it might be a particularly appealing way to reach them.
Well, in the interest of time, we have about 4 minutes left. I'd like to open up the conversation to some discussion at this point. Just any final questions or comments that our participants might have for either Jane or Karen?
This is Mike. I just want to have one thing that I found that I couldn't do. I could not print out Dr. Ingersoll's PowerPoint. I got Dr. Simoni's, and I was wondering if with that follow-up email, if you could maybe resend that somehow to me.
Absolutely.
Thank you.
Anything else? Any other follow-ups or questions or comments?
I guess I'm wondering for the whole group, and I don't know if folks are still muted, so if you are, you can unmute yourself. You know, the things we've touched on today, which things feel like you might be able to try them out or incorporate them into the work that you do?
And again, if you are muted, you can just dial *6 to unmute your line.
This is Mike, and I think the one thing that really struck me, and I'm going to go back to the staff that I work with, is just kind of remembering that the priority list that we have may not be the client's priority list in life. And we need to just kind of open that up to understand where they are. We assume that because our world is HIV and taking care of them to the best of our ability, that that's their priority too, and that's not always the case. So thank you for bringing that to my attention.
This is Sue, and just to piggyback what Mike was saying, and I wanted to thank you all for an excellent hour and a half, very enlightening. I am reminded again of the importance of relationship, and it's often the way that we relate that's just as important, if not more important than what we say. The small things often that make a big difference, and just wanted to add too, and I have to remind myself of this often, is that in assessing where the client is in their life and what their priorities are, they may not be ready for change in terms of changing their behaviors regarding adherence. That's a really key aspect to consider, and rapport building takes time to develop that trust, and that's not something that we have a lot of, that any of us have a lot of, but the therapeutic alliance, so to speak, doesn't happen overnight. So I think it's important for us as professionals working with our clients, with our patients, to keep that in mind, that it's a process that can't be rushed. Sorry, I'm losing my voice. So thank you again, everyone, and participants alike.
And I wanted to take a moment to thank Dr. Simoni and Dr. Ingersoll for joining us today, and to thank our participants who hung with us. For any of you who have participated in AIA webinars in the past, you've known that we tried something new this time, and I think it went pretty well, but thank you all for being our guinea pigs, so to speak. You know, instead of just going through the PowerPoint, we tried a more inclusive discussion as a webinar. So thank you for that. We'd love to hear how you feel it went, so if you could follow this link here, a brief online evaluation will pop up. And we'd like to get the feedback of everybody who listened today. So if you're listening with a group of people, if each person could go to that link and fill out the survey, that would be really helpful to us so that we can influence our webinars in the future. Our next webinar is on April 3rd at 10 a.m. Pacific. It's called Creating an Effective Peer Model with Dr. Paul Coulson. You can see our website, aia.berkeley.edu, for more details. Thank you again, and I hope that everybody has a wonderful day.
Thank you so much.
Thank you very much.
Thank you.
This concludes today's conference call. You may now disconnect.